Good afternoon, everyone, and welcome to the COVID series of the Institute for Global Health Sciences. I'm Jaime Sepulveda, Director of the Institute. We have a very fascinating and important topic today, which is communities of color and COVID. And we have two fabulous speakers that I will introduce in a second. One is Dr. Alicia Fernandez, who is a professor of medicine and an internist at the San Francisco General Hospital. The other speaker is Dr. Kim Rhodes, who is an associate professor at the Department of Epidemiology and Biostatistics, and also director of the Office of Community Outreach and Engagement at the Cancer Center. So the communities of color and COVID is particularly relevant given the huge inequalities that we see. We have reached a very tragic milestone in the US. 500,000 people have died of COVID. Just think of this. These are more deaths than World War I and World War II and Vietnam War combined. Now, the burden has not been equal. Even though as a whole, the US population has already lost 1 year of life lost due to COVID, which means for people that have died, 13 years of productive life lost. But the realities are reflected in that Latinx communities have lost 3 years of life lost. Black communities in the US have lost 2 years of life compared to 0.7 years of life lost for whites. So the pandemic is affecting disproportionately vulnerable populations, communities of color, and we need to understand why is that and what we can do to modify that situation. So for this, we have, again, these two very knowledgeable speakers that will be talking about Latinx and Black communities. Let me give the floor to Dr. Alicia Fernandez. Alicia, welcome.
Thank you very much, Jaime. It's a pleasure and honor to be here. I'm really always happy to present for global health, and I'm particularly delighted to be presenting with my colleague, Dr. Kim Rhodes. Let me start sharing my slides. Let's see, doing here, going to here, and going here. I hope everyone, is that good? I hope so. So let's talk a little bit. I think some of what I'm going to say echoes what Dr. Sepulveda just said. The first thing is to consider how many is 500,000 deaths. Well, the easy answer is to say it's 500,000. The problem is that it's very difficult for us to comprehend that number. I really liked this graphic that the Washington Post did. They lined up buses where each bus carries putative 50 people. And they said, if you put all the buses together into a caravan, bus after bus after bus, what would that mean? And to require 500,000 people, it would require 9,800 buses, and that would stretch the distance between Philadelphia and New York. In other words, this is an enormous magnitude of people. And this, thanks to Dr. Sepulveda, who sent this to my attention, this is the slide that references the data he just gave. What we see here is that this is life expectancy on the y-axis, and among Latinos, what we see is this horrendous drop of life expectancy of 3 years. Note that Latino life expectancy is higher in general than that of whites or the total population in the United States, driven, of course, by the immigrant advantage of foreign-born Latinos. And see here, this slide, the line, the orange line for African Americans, the chronic disadvantage in life expectancy made worse now with this projected drop of over 2 years of life expectancy. These are enormous drops. It is really, truly difficult to comprehend the amount of life lost. Switching now to California, I think you're all very familiar with these. These bars represent the proportion of people in the population, and the blue bars represents the number of cases. And you can see that among Californians, Latinos have far exceeded in cases their numbers in the population, whereas for whites and even Asians, the numbers are smaller than that of the population. And unfortunately, when we look at deaths, we see large deaths for African Americans and for Latinos. This is unadjusted data from the California DPH. And what it shows is that within these groups, you can see the case rate. The statewide case rate a few weeks ago was at 32. And among poor people, it was at 36 per 100,000. Among wealthier people, it was at 12 per 100,000. And likewise, when you look by the percentage of the census tract living in crowded housing, defined as more than one person per room, we will see this very nice step down. When in the communities that have more crowded housing, there are more cases. In the communities that have less crowded houses, there are fewer cases. And then given that 20% of Latinos are still without health insurance, you see also this step down in terms of the proportion of community without health insurance. If you want to look at this more formally, this is from a study I was fortunate enough to participate as a small author by Alicia Riley and led by a senior colleague, Kirsten Bibbins-Domingo. We looked at excess deaths among California Latinos and found that most of this is among Latinos. The excess deaths represented as distance from above the orange bar was much higher among Latinos born in Mexico and in Central America than in Latinos born in the United States. Let me say this another way. This is not a Latino epidemic. This is an immigrant Latino epidemic. And on top of that, it is an epidemic among workers and among people who have no high school education. So foreign born plus essential work plus limited education really defines the death toll. And you can also see that here, where you see it as non-essential and essential workers and so on. So who are these folks? In a study I did not participate in, but also done by Dr. Bibbins-Domingo and her colleagues, it turns out these folks, they were able to look at occupation, which the death certificate data has. These are farm workers. These are folks that work in grocery store. Lots of folks working in food industries, specifically as cooks. People who work in warehouse or as janitors. And people who, people who work in food preparation. So when I said food workers, it's not only cooks, but people who work in food farms, be it poultry farms, as happened in Southern California, or other form of industrial preparation of food. And then in urban settings, lots of construction workers. So we have a good sense of who are the population that is most at risk. Turning this now to a hyperlocal event, I'll tell you about a study that actually was a community testing event that we were fortunate enough to participate in the Fruitville community in Oakland in September. And Fruitville, for some of you may know, is one of the poorest communities in Oakland. It is about half the people who live in Fruitville are Latinos, and it has, at that time, more cases than any other part in more cases than any other Alameda County. Working using a test and response model that had been previously used to great success by my HIV/AIDS colleagues led by Diane Havlier in the Mission District in San Francisco. We partnered with a large number of community groups, health groups, including Clínica La Raza and other people to put together this event. And this is what we found. We found that among non-Latinos, there were very few people who were PCR positive. We tested over 1,000 people who were PCR positive or antibody positive. That positivity rate jumped dramatically when you looked at Latinos. And then when you looked within the Latino population at people who self-identified as Mayan, there is a large population of Guatemalan immigrants of Mayan origin. And we asked them, are you Mayan? The people who said yes were more likely to have PCR and antibody positive. They were also more likely, Latinos in general and Mayans specifically, to live in larger household sizes. And more likely, even in this relatively poor community, to say, answer yes to standard questions about food insecurity. So you start to see this packaging of vulnerability even within people who are vulnerable. And likewise, we see this as in household income, with Mayans being overrepresented among folks in the lowest household income group. We have a paper under review, and I show this only to say to you that even when you don't look at stratified data, but instead you look at it properly adjusted, being Latino versus non-Latino, and being Mayan versus non-Latino, or even Mayan versus non-Mayan Latinos, we still see that these are separate risk factors. This is no surprise. This is a social virus. It travels along social networking lines. And once it gets into a community, that combination of crowded households makes it much worse. So we were fortunate to do this work in this coalition and through the use of volunteers to gather all of this data. And I just want to point out that one of the big things that the working in the pandemic has done for me is really highlighted the ways in which my skills as a researcher can be useful. And in this case, it was useful in terms of presentations to the Oakland mayor and the Oakland City Council. It was these data have consisted of the backbone of the coalition's request for economic relief to this community, relief which is being granted. And then also it has strengthened the partnership between the Alameda County of Public Health, community-based organizations, and clinical sites in Alameda, and been able to highlight areas such as with the Mayan community where the Alameda County of Public Health and community groups may wish to partner to do more outreach. Now, none of this is different. I used the Oakland example because I was personally involved, but none of this is different from what's happened in San Francisco. You see here that in the more Latino areas, in the poorer areas of San Francisco, and of course in the Bayview, which is now African-American, Latino, and Filipino, very, very high rates of cases. With over 10-fold differences between the high zip codes and the lower zip codes. We understand now very clearly the drivers of COVID excess case risk among Latinos and others, and that is the need to work outside the home and congregate housing, be it multi-generational housing or be it some other form of congregate housing. I always tell the story of my own patient who spent a month in the ICU. And when I talked to her before I ended up having to admit her, she and her adult disabled daughter shared a room. And I was like, okay, and who else lives there? And it turns out that they shared a room with 8 other non-related adults. Actually, they had their own bedroom, but they shared the apartment with one kitchen, 2 very small bathrooms and a total of 10 unrelated adults. That is what we call congregate housing in these high cost of living, expensive markets. Those 2 things, work outside the home and congregate housing, obviously are what drive cases. What drives excess death are the number of cases. You have enough cases, you're going to have more deaths, and we see that. Obviously, comorbid conditions, and in particular among Latinos, obesity and diabetes, and then access to care. In a qualitative study that we did, interviewing patients discharged with COVID from San Francisco General and from Denver Health, it astonished me how in these 2 sanctuary cities located in sanctuary states, where by law the health system is not allowed to share information with immigration, how many people delayed accessing healthcare because fears of a big bill or fears of immigration. I really like this drawing from a British epidemiologist, because I think it's important to capture all of these thinkings about how COVID has impacted our communities. What we've been talking about is the morbidity and mortality. We have not yet talked about the impact of resource restriction on urgent non-COVID conditions, but I would tell you that in the excess death studies that I have been involved with the Department of Epidemiology with Dr. Bibbins Domingo, about 2/3 of those deaths are labeled COVID and about 1/3 are not. And that may represent mislabeling, or it may represent resource restriction on non-COVID conditions. We have yet to see the full wave of impact on interrupted care on chronic conditions, but we already have seen the huge impact on mental health, not only among adults, but among children, as has been documented even locally in terms of the children's hospitals here at UCSF. Finally, I add this line, which is a line of economic injury. And this is where we're really seeing that poor people have gotten way poorer, partly because economic relief has not been as forthcoming to immigrant communities. And for that, again, I want to share some immigration-specific issues. One I mentioned, which is immigration fear in terms of for undocumented. But I think that many people are unaware that public charge is not something about undocumentation. It is a restriction put on legal permanent resident, green card residents, that prohibits them from incurring certain quote unquote public charges, including access to Medicaid under the Trump administration, because those considerations can count against a citizenship application. So again, there are concerns about all of this, not only among the undocumented, not only among the 70% of people who live in mixed status housing, but also among legal immigrants. You all will remember that the CARES Act, which was the first big relief act, and actually both CARES Act excluded anyone who lived in a household where people used an individual tax number to file taxes. And what that meant is that if an undocumented immigrant was, say, married to a documented, to a US citizen, that household was excluded. And this rebounded to the fact that 8 million US citizens, almost all of them children, were unable to gain relief. A few highlights that we can get to in Q&A. Most of this has been a tremendous failure of workplace safety. This has been a failure not only of the federal OSHA, but also of Cal OSHA. Cal OSHA did not put out guidance until late December on how workplaces needed to respond to the COVID pandemic. There are many reasons for that, but it has really been a very unfortunate policy failure. Does it matter? Yes, it seems to matter tremendously. This very interesting study was done, published in Health Affairs, you see the citation below, showed that if you looked at nursing home deaths, and then you looked and cross-filed that with whether or not those nursing homes were represented by a union, nursing homes where the workers were represented had fewer deaths and were also associated, not surprisingly, with more access to protection. So not only were workers more protected, but the nursing home folks, the residents, were more protected. There have been some bright policy points, partly as a result of the work and the mission that Dr. Havler and others did, and both San Francisco and Oakland are making available funds for people who, for undocumented immigrants or people without sick leave access who test positive. It's minimum wage, and it is available when funds are available. Because they're using philanthropic funds, much of the time funds are not available. So very rapidly, vaccination, we can talk more about this. I am of the camp that says we need an age plus place strategy. We need to go, we need to have people come to get a vaccine, but we also need to take the vaccine to where people are, to the high zip code areas. And that clearly we need partnerships with community health workers, with CBOs, and with Spanish language media. In terms of doing our share, we have created a UCSF speakers groups. We have over 60 volunteers. We have 109 engagements either done or scheduled. Lots of that has been with CBOs and with unions. The largest one I participated in was a call with 23,000 people sponsored by SCIU. But we're also proud to participate in calls with 30 people, as we've been doing with IHSS workers in 6 languages. If you wish to participate, the next training is tomorrow, and you can email Alice Fishman. What we're looking at now is we're trying to get some sort of funding for a community health worker, promotora type strategy, which would be highly local, boots on the ground, helping people navigate how to get a vaccine, but also one by one answering people's questions for the vaccine. So with that, I'll say what you already know, that COVID has been a great catalyst for disparities, not only a great revealer for people who actually didn't know there were disparities, but a great enforcer. And at the same time, and as I hope this whirlwind showed you, it has been a great opportunity for health equity researchers such as myself to learn to work within different systems, different partnerships, to try to engage in social policies and to redefine what does it mean to be a physician researcher. Thank you. Let me stop here.
Thank you so much, Dr. Fernandez. I think you have presented very well the huge disparities that exist in communities of color, in this case, Latinx. And I'm sure there will be many questions and comments about how to deal with these inequities and what else can we do. Now, please allow me to introduce again Dr. Kim Rhodes, and she will be talking about the same aspects for communities of color in Black communities. Dr. Rhodes, please.
So thank you so much for inviting me to share our experience working in the African-American community around COVID, and really appreciate my colleague Alicia Fernandez and her presentation of a tremendous amount of data. Even though it highlighted the Latinx community experience, I think it was very easy to see that the African-American experience was looking somewhat similar. So I'm not going to repeat the presentation of data, although there is one, but I'm going to focus more on sort of health equity and these kind of concepts and concerns about trust in various communities. But I do want to share one piece of data that in our work with the Alameda County Public Health Department and Mayor Libby Schaaf's task force on COVID equity, that we started pressing as a group to get the department to start to report case fatality rates. Because what is sort of missing from the conversation and from, I would say, most public health department dashboards in the Greater Bay Area at the very least, is an assessment of what is your risk of dying if you were to get COVID. And I just want to point out and underscore what was brought to the forefront in a ProPublica article a few weeks ago, that really the risk of dying from COVID is quite high for the African-American community, even though the rates of infection do not quite match that of the distribution in the Latinx community. So, and the ProPublica article really pointed out that the risk of dying from COVID is really borne by African-American men. And I think that's important as I start to tell you what we've done in Oakland and who's involved, which was truly, in fact, serendipitous because folks were not looking at these numbers at the time that, that we started our efforts to try to increase testing in these communities. So I'll just start by saying that I am the Associate Director for Community Engagement for the UCSF Cancer Center, and our Community Advisory Board has been together for 15 years. Tremendous hat tip to Rena Pasick and Bob Hyatt for pulling together a Community Advisory Board before Community Advisory Boards were popular, and really trying to listen to and be responsive to the voices of and concerns of community. I took over as Dr. Pasick's successor in 2018. And what the things that we had planned for 2020 really focused on cancer. But what ended up happening, as everybody knows, is we were hit with a pandemic, and our community partners started asking specifically for COVID information. And we found ourselves delivering information about webinars and seminars, and particularly things that were being put on by the Latinx Center of Excellence and the Asian Health Institute in language information for our partners. And what we realized is as we were sending it out that we didn't have anything specific for African-American community. And that really bothered me because we were being asked to deliver this information. And here I was sitting in a position to have the information, but not necessarily being connected through an institutional structure to the African-American community. And so again, I want to also acknowledge Dr. Malcolm John, who subsequently, and in part due to some of the discussions we had, put together the Black Health Institute, which we hope to see thrive in the future. But one of the key people on our community advisory board is Arnold Perkins. He's been with us for 15 years. He used to be the director of the Alameda County Public Health Department. He appointed Mr. Michael Shaw, who runs the Office of Urban Male Health, and they really were the touch points for us as we got started in Oakland, working on increasing COVID testing and COVID awareness in the African-American community. And I'll get to that in a second, but I just want to set the stage for why the situation for African-American folks looks a lot different than immigrant populations. And in the same year that we had our 15th anniversary of the CAB, it was, as Arnold says, the 400-year anniversary of the enslavement of Black people. I want to talk just briefly about the concept of otherization. And in this great little book, it's a quick read by Toni Morrison on the origin of others. A couple of things are emphasized. The first thing is that, you know, Black people are not immigrants. So our history is one of displacement and separation. From the time we set foot on this US soil, we were dispersed in terms of our families, split from each other, and then mixed together into groups of people who could not communicate with each other. So it was a very intentional way to disempower a population. But Toni Morrison writes about the idea that slavery required this concept of otherization in order to justify itself. And I'm just going to read a quick passage from her writing in this book. She notes that the forced exercise so beneficial to the Negro is expended in cultivating cotton, sugar, rice, and tobacco, which but for his labor would go uncultivated and their products would be lost to the world. So both parties are benefited, the Negro as well as his master, which of course seems ridiculous now, but that was the foundation of how Black people were seen in this here United States of America. We went on further as academic institutions, as medical institutions, to codify this otherization by talking about the clinical and medical definitions of being Black. And just a second passage from the report on the diseases and physical peculiarities of the Negro race from 1851. Negroes can only have their intellectual faculties awakened in a sufficient degree to receive moral culture when under the compulsory authority of the white man. So these were things that were published sort of in our literature. And the census of 1860 and 1870, after the abolition of slavery, effectively predicted that Black people would go extinct because they would be unable to survive due to their lack of culture, if you will. So this is kind of where we start, and when we're having conversations about trust and relationships between the African-American community and academic institutions, medicine, science, et cetera. We all are very familiar with the Tuskegee Experiment. I think the one thing that I like to point out about the Tuskegee Experiment was that it was only supposed to last 6 months, but it ended up lasting 40 years. And it only ended because of a whistleblower event. And then in that case, it only ended in America, it then moved itself to Guatemala. But what people may not be aware of is that the CDC, which was the Communicable Disease Center at the time, was started on 3 diseases. One was TB, the other was malaria, and then the third was syphilis. So it's not just a matter of an atrocity of a human experimentation without consent that went on. It's that one of our primary public health institutions was actually founded on the study of syphilis through this experiment. And finally, there was partnership that actually went on. And I like to joke that, you know, if the Tuskegee Experiment went to study section, you know, somebody might say, well, at least they've got a Black nurse and some Black doctors. And I think what's important to point out is they were also, may have been duped at the time, but were involved and therefore somewhat complicit. So just being the same color as the community that you're trying to work in doesn't necessarily mean that what you're bringing is aligned with the agenda of the community versus being aligned with the agenda of the academic institution. So these are deep roots to the otherization that African Americans face. And some people might comfort themselves by saying, well, that was a long time ago. But the reality is this otherization persists in healthcare. And there are numerous studies. This was one of my favorites from 2005. People may recall the Schulman paper, where videos were made by African-American men and women, as well as white men and women, complaining of giving the same complaints in a video presentation with the same comorbidities, being the same age, and being actually diagnosed and assigned differently by the participants in the study, which were cardiologists, as to whether or not they would get cardiac interventions. And if you just look at the social totem pole and you say, well, men trump women and white trumps Black, what you will then appreciate is that it was Black women who were least often referred for cardiac interventions. And this really just reflects a deep-seated belief in our institutional culture about who is a risky patient or who may have a bad outcome, and therefore you may not want to be doing procedures on. Now, that was back in 2005. This paper was published by my dear friend, Lenny Lopez, at the VA, the head of hospital medicine, looking at millions of cases of folks going into the emergency department complaining of chest pain. And we sort of jokingly call this chest pain while Black. But what they found was that Black and Latino patients were less likely to receive be triaged emergently, number one, with a complaint of chest pain, less likely to get aspirin, less likely to be hooked to cardiac monitors or referred to a cardiac unit. And then in 2012 or so, as well as 2015, you know, my work really started to show that the differences in the quality of care for different types of cancer could explain, in large part, some of the disparities gaps that had been persistent over time. And need I say more? So lack of trust that, you know, is now at the forefront of what we're discussing really should be thought of as an expected response to historically untrustworthy behavior. And I know that at UCSF, we're now starting to incorporate this into our common parlance, and I'm really appreciative of that. because what it does is it turns a lens on our role in creating the relationship or lack thereof that is going to potentially impede us from getting to vaccination in African American communities. And then I just also want to finally say that the big dilemma of being the other is that as the other, if nothing is designed specifically for you, and I'll use in this case for COVID, the example of testing, it took forever to get testing into African American communities. You saw providers and activists all over the country setting up, having to kind of, do boots on the ground to get testing into African American communities. So when something is advanced as being for you, like the vaccine, it really is for you because ... it seems suspicious because most things are not for the African American community or for any other group of people who are defined as other. So then to be asked to step forward, I think I heard it captured best on a call with SFDPH and some of the community partners from Potrero Hill who said, you weren't fast to get us testing. Why are you so fast to want to vaccinate us? And I think this is a very valid question. And the unfortunate problem is that misinformation and disinformation are easier to accept because it reinforces the suspicion that something's wrong. You're trying to vaccinate me with, you're trying to inject something into me. I've heard a chip. I've heard a number of different things. You're trying to cause infertility. Again, historically based concerns. So this is the problem that we're facing as academic institutions, as investigators, as researchers, as community collaborators even. One of the things that Arnold always says that I love so much that really, really captures what we need to be doing and the thing that would flip sort of our traditional paradigm on its ear is you can't teach what you don't know and you can't lead where you won't go. So taking this to heart and following the lead of Arnold, as well as Michael Shaw, the director of the Office of Urban Male Health at the Alameda County Public Health Department, we put together the Umoja Health Partners. And I want to just really acknowledge, first of all, that Dr. Frank Staggers, who is a Bay Area legend, was the founder of the Faith Communities Committee, which has been together for 13 years inside of our Office of Community Engagement. That group of men pivoted. They had planned a prostate cancer walk in Alameda County around Lake Merritt. And when COVID hit, they immediately pivoted. They said, we've got to get our community educated. We're going to start printing masks. We're going to hand out masks and hand sanitizer and provide information for our community. And then they were asking, what more can we do? So in the process of Fruitvale reaching out to UCSF, and I was asked by Dr. Bivens Domingo to come along for that effort, I started thinking maybe we ought to do something in Deep East Oakland, partly because our partners on the Men's Health Committee that spawned the Friends of Dr. Frank Staggers were already doing the work. So through them, we were able to connect to the Brotherhood of Elders Network, which is a broad network that includes CEOs, some of the Black CEOs of large foundations. We connected with the Oakland Frontline Healers, which is about 20 to 30 community-based organizations, as well as clinical partners in the Oakland Frontline Healers. Elected officials became involved. Our faith partners came along. And through this network, we were able to then link to all of these other community-based organizations who are all committed to doing something in the African American community. Of course, infrastructure provided by UCSF. Thank you to Dr. Hoggood, the chancellor, for his generous support. And then in partnership with the Alameda County Public Health Department, because of course, due to Arnold and Michael Shaw's connections there and our previous efforts in planning prostate cancer initiatives, we were already sort of linked up with that group. So what we decided to do, in contrast to having a massive testing site as we had done in Bayview, Hunters Point, and Sunnydale, where what we actually saw was an increase over the 4 days of testing, of low barrier testing, high throughput outdoor with COVID safety. What we actually saw was over the course of the 4 days, the percent of white participants increased. So where we were expecting to see 4% white participants, we actually saw 17 to 20% at those sites. So what we decided to do is go smaller while we were in Oakland. We looked at the census tract data, and in the dark patches, that's where the African American population represents over 40%. And you can see the history of dispersion. We've got East Oakland and West Oakland having census tracts where we needed to pop up. The green dots show where we did pop up. And that those sites were selected by the community and matched to the census tract. They took us to places where African-American people were already going to gather, so we knew that's who we would be reaching. And we set as a goal to get more than, we said at the time, 80% of our testing resources to the African-American community. So we were born at the Acoma Market on September 6th when the Acoma Market was born, and now we are forever sort of married to the Acoma Market in Deep East Oakland and Liberation Park. Our mobilization is done by African-American men along with African-American and other diverse youth from one of our church partners. They go out and on the ground, we call it hand-to-hand combat. They answer questions. Everybody doesn't come to our testing pop-up, but if they get one of our flyers that's designed by and for the community with the name Umoja Health, again, selected by the community, meaning unity in Swahili, then those folks have been touched with some information about COVID. So we ended up using as our metric, and I love this because our community partners and everybody who would get on our weekly call, which is still ongoing, would always be very focused on what % African-American testers are we bringing into the site this week. And so even during the course of the pop-ups, they'll be running up to me and saying, I think the numbers look really good. What do you think the numbers are gonna be? We meet at 4 o'clock this afternoon. We're gonna look at the numbers from the pop-up on Sunday. But what I'm showing you here is we're comparing our reach to African-American population compared to the two clinics that serve African-American population, both East and West Oakland. And what you can see is that we at times doubled or tripled their reach to African-American community. And I think this is because of what we were doing actually on the ground. We also asked everybody who came to our sites, and by the way, we tested 1,000 people. There were only 7 positives. Of those, only 2 were African-American, so 2 out of over 50%. I think we tested 57% of our total tests went to African-American community. So again, we saw the infection rates were quite low, but again, our concern is the case fatality rate. So we were asking about being open to vaccination, and that's because we know the vaccine may not prevent infection, but it certainly prevents severe COVID hospitalizations and we hope death. And so we asked, and what we found was half of our participants were open, but when we stratified it by race ethnicity, you see that 40% of African-American participants were open to it. And you might say, well, gosh, that's lower than everybody else. But when we compared to the national polls at the time, we exceeded those polls by about 20%, with African-American openness being at 32%. Most recently, since we've been testing, we've shifted to a saliva-based strategy because we know that our community doesn't want the nasal swab. And so we're also trying to find out if people are preferring the saliva-based testing over the nasal swab as part of our survey process, which, by the way, all of the surveys are administered by community participants. The whole site is run by volunteers. I'm probably the only UCSF faculty on site. There is no branding that says UCSF. There's no branding that says Public Health Department. So when people come on site, they're being welcomed by their fellow community members and neighbors. So most recently, we've run this represents about 2 pop-ups that we've done so far, and 51% of folks are saying that they're open to the vaccine in the African-American community. And this obviously, again, compares quite favorably to national polls by Press Ganey at the beginning of February, showing a 39.5% openness rate. So what I want to kind of finish with is this idea that trust builds at the pace of the relationship. So you have to ask yourself, when we ask about how do we build trust, I think we need to step back and ask, well, what kind of relationship do we have with the community? Because if you don't have a relationship, you really shouldn't expect to have trust. Now, we are, as clinicians and as researchers and as smart people who do the science, yes, we are revered in some spaces, but from what I showed you at the top, those spaces have called and named and codified African-American community as other. So this is not a place where we have a shared kind of mutual understanding of the value of what each of us are bringing to the table. So this is why we think Umoja works. There's an emphasis on cultivating an ongoing relationship. Everything we do is very intentional. Our tents are black, green, and red. Our naming and collateral materials that we hand out are designed by community. Everything is for us, by us, or FUBU. And we have deep community engagement. We have persisted with meetings since the beginning of August. Every week, we share the data back in real time, and we give the community an opportunity to comment on it. We post the data publicly. We don't embargo it waiting for a publication. Our agenda is the community agenda and the public health agenda, not necessarily the academic agenda. We get that where we can, but it's not in the forefront, it's in the back. So thank you so much.
Thank you so much, Dr. Rhoads, for this profound and comprehensive review. I really like the notion of other and otherization, and I think this will lead to a meaningful conversation and discussion. We have very many participants who have already started posting comments and questions for both of our speakers. I would like to start the conversation around this so-called vaccine hesitancy, which I think might be a misleading concept. And I would like to start the conversation asking both of you why this labeling is problematic. And allow me to also introduce my colleague, Kemi Amin, who will be helping me in handling the questions from the audience and posting her own. So who wants to go first?
I'm gonna hop in because I'm hot on this one. You know, we don't use the term vaccine hesitancy in any of our circles. And it is partly because there is sort of a judgment attached to it. It is as if there's something wrong with you if you're not running for this vaccine. When in reality, you know, everybody has questions. This is new technology. And it is not unreasonable that they want more information. So the idea of hesitancy sort of says, like, I don't know why you want more information. And then the other thing I will just point out that it is actually code for Black and brown communities, because who is shutting down the LA vaccine site? It's not the Black and brown communities, it's the anti-vaxxers, but we don't talk about hesitancy in those communities. And so it's very clear that it's code. And I think that unfortunately, given the status of otherization, that code is somewhat discriminatory.
I completely agree with Kim. And I would add only 2 points to the excellent ones that she made. One is that right now in the United States, the group that the largest proportion of people saying that they are not ready to get a vaccine are Republicans. That's right. So this is, if you look at these surveys, like the Kaiser Family Fund and other surveys, this has all been published in the New York Times. This is not hidden data, right? It really reflects the politicization of science on the one hand, and of course the historical legacy of abuse on the other, as Kim so eloquently described. The other thing is that even if you accept the concept, which is fine, you know, there are people who are, you know, absolutely quite worried about taking the vaccine or don't want it. The WHO defines vaccine hesitancy as people who don't want the vaccine when it's available. And what I think is amazing is how many people want to shift the conversation to vaccine hesitancy instead of saying what they're doing, which has made the vaccine not available. So for example, we have many health systems, including many in San Francisco, who have only put out information about the vaccine through electronic medical records, MyChart or the equivalent. We know that older people are disproportionately not on them, and particularly older people who are from low-income communities, and specifically African-American and Latinos. So you send out the message there, and then people don't come, and you say, oh, there's a lot of vaccine hesitancy, instead of saying, why did I do it that way? If it's not available, it's not hesitancy.
Very good point.
That's the pretext, right? When we finally get the numbers, for example, from the Coliseum FEMA site, and there's a huge gap, they're going to say, well, there's hesitancy. And so that, somehow that gap is acceptable.
We get a lot of questions. Kemi, do you want to address some of the questions, please?
Yeah. I actually have one question that I have lined up that speaks to one of the questions that the audience has posed. So I really appreciate your feedback on that, because, honestly, when I Google communities of color and COVID, all I see is vaccine hesitancy. And, it feels like an effort to pathologize, communities of color. And so given the vaccine, most COVID vaccines require 2 doses. What are some strategies being employed to ensure, or what are some strategies that can be employed to ensure that people are coming back for their second dose, but even getting vaccinated in general?
I haven't heard of problems with second dose. Most of the things that I have heard, and I haven't seen any data on this, I don't know if Kim has, is really getting people to that first dose. And I think that both of us would say that there is such a real thing as people really being slower to warm up, let's put it that way, to the vaccine based on this history of abuses. So I do think that we do need to do much more work, and that's where different sorts of programs like the speakers group that I described, like some form of ambassador or community health worker, or I think, Kim, you call them conductors, knocking on people's doors, telling people how to get the vaccine are necessary. But I have not heard a problem. This is all going to become enormously more complicated in about a few weeks when Johnson & Johnson gets approved as a one-shot vaccine, which is less efficacious in preventing, it appears to be, science by press release, appears to be less efficacious. So what we're going to hear is a tremendous pushback. Oh, they want to give us the vaccine that doesn't work. Right. Because, and we're gonna, I want to leave it for a longer discussion about, does it work and it prevents death and so on and so forth. And we need to see this, we need to see the actual data. But what is going to happen is that it's going to further muddy the conversational waters, I suspect. So be on the lookout for that.
So we just found out, so this is new, it's like half baked. So Umoja Health has just found out that Alameda County is going to be providing an allocation on a regular basis as if we are a clinic to Umoja Health, in part because of data that I didn't show you about who we reached in terms of people who are way outside of the healthcare delivery system. They're not plugged in, they're not connected, but we are, because we're plopping down at Champion Smokehouse Barbecue on 98th and Eads, right, that we're able to reach those folks. So what we're going to do is transform the respond component of our test and respond efforts. We have a case manager who calls people on a daily basis, finds out what they need. We send them groceries. But what we will be doing is having a bank of case managers who can actually call people back. So there will be an automatic notification with the back end IT system we're using. People will get an automatic notification, your second dose is coming. But we're actually going to continue to be person to person and function sort of in that person to person role. And then the other thing that we added at our pop-up on Sunday, we were under the impression, and when I say we, I mean, there are probably about between 45 and 50 people who show up on the Umoja meeting call every week. They don't all work at the pop-up site, but everybody's contributing. We call it kind of stone soup. People are bringing whatever resources they have to the table. We offer social services at our sites. So addressing housing, back rent, food insecurity, getting people signed up for healthcare. So this time what we did was we placed someone with a computer who, if folks were done with their testing and they were interested in being signed up for vaccination, we actually got them over the hurdle of signing up and doing that IT piece for them. And then we also incorporated an Ask the Expert. So we have one of our local physician partners sitting at a table waiting to answer any questions that people might have. So we're going to continue to use that same kind of model that gives people a touch point, a hotline, a place where they feel that they can reach to in order to get this information. And as far as the confusion that's going to come with J&J in one shot, this is part of why we have a weekly meeting. So we've already talked about J&J. We've already talked about that it's one shot. We've talked about the fact that yes, it's less efficacious by percentage, but then we remind people that the polio vaccine was only 50% effective. So we got spoiled by Pfizer and Moderna being 95, 96% effective. That's not the norm for most vaccines. So we've talked about community immunity. We've talked about the variants. So people are getting this information in small doses so that we're not trying to give it to them all at once and we're not going to see you again. We're going to see you next Tuesday. And if you have other questions, we're going to be here for that.
We only have 5 minutes left. Is there something you recommend that we as faculty, staff at UCSF can do to better communicate? I am on TV shows for Hispanic communities, Telemundo, 2-3 times a week, radio stations. And what I hear from the public is a lot of misinformation, a lot of conspiracy theories and distrust. Mm-hmm. Is there something you think we can do more and better as academics to spread the right information to the right communities at the right time?
Yes, I think so. And I want to be very brief because I want to get to more questions if you have the time. But it is, I think that like you, I do a lot of speaking. The problem with speaking is that it's unidirectional. And what is needed here is dialogue. And that's why we started the speakers group, because we do a presentation that is 10 minutes long. It's actually 8 to 10 minutes long. And then after that, we spend the time answering questions. Because people, particularly with communities with low literacy, as you know, which is true of most immigrant communities, people want to be able to say again, well, I have diabetes, can I still get it? Even though you already said in the presentation, it's fine, you know? And you have to say, yes, you can. I have asthma, can I get it? Yes, you can. And then you build the knowledge base. But without dialogue, it is very difficult to make change without dialogue. And that's why we need all of this. We need people like you speaking. We need social marketing campaigns. And then we also need people like the volunteers in our speakers group or like a promotora type model where people can ask their questions.
Thank you, Alicia. Dr. Rhoads, 1 minute for you to conclude.
I just will reemphasize trust builds at the pace of the relationship. And what we don't do well as academic institutions is maintain relationships with community partners. We have an agenda. It's usually funded by a foundation or the federal government, and that has restrictions around how long you can stay. So in our Office of Community Engagement for Cancer, what we see ourselves as and what we're offering ourselves as is institutional partners. We're there all the time. We say we do year-round, non-transactional community engagement. The non-transactional piece is we're not always bringing a study or asking you to fill out a survey. Sometimes we're just there to give information or link you to services. And that means that then the academic folks can come in and out and do their research, and it doesn't leave the community feeling abandoned. And so everything we do is really about building a relationship and sustaining the relationship. Because when COVID is over, will we still have a speakers bureau? I hope so, but we might not. And that will look like we left the community once again. So I would just continue to advocate for us stopping thinking about ourselves as separate. And even in how we get taught in medical school, we're the doctor, the patient is other. We will never be the patient. That's why doctors are terrible patients, right? Because we were taught we're never the patient. When in reality, yeah, we are sometimes. And so we need to start to see ourselves in relation to community in the same way we see ourselves in relation to our friends. I don't do outreach. I know that's in my title. I only reach out. And the reason is because if you think about the population that you would do outreach to, versus who you would reach out to, if they're different, you need to ask yourself why. Because what we have in common is that we're human, we need information, we can be vulnerable, right? And so that exchange is a place where we've got certain information, but it doesn't make us better. And if we could see ourselves as part of the community rather than separate from the community, I think that we would have a much easier time in terms of dealing with this disinformation and misinformation.
Well, thank you to you both for a really fabulous talk. I have a couple of housekeeping things. One, we have extended our master's application to March 15th. And also, we're having on that very same day a lightning lecture by Dr. Laura Smith. Our next COVID series on March 9, we have two wonderful speakers, Dr. Stefano Bertozzi and Dr. Bree Williamson, and we will be talking about COVID in prisons, the high rate of COVID-19 in incarcerated people. So please join us on March 9 for that COVID series. Again, thank you, Dr. Rhoads. Thank you, Dr. Fernandez, and have all a safe and pleasant week. Bye now. Thank you.
Thank you.